My name is Alan Pitt. I'm an attending physician at the Barrow Institute in Phoenix, Arizona. I'd like to talk about moving from the pager to communication in the cloud. Most of us know the problem when we want to reach somebody for help. We have to call them or page them. They get the page and then they call us back. There's a conversation about what to do next. In an ideal world, there would be an exchange of information, including imaging, the EMR, and even live video of the patient so that accurate and timely decisions could be made about next steps. This is a much richer information exchange. This is along the lines of telehealth, where there's much more than simply a phone call. However, telehealth in general has been expensive, with initial capital as well as ongoing support for both spoke and hubs. In an ideal world, what you would really want is to replace the large, clunky equipment with ubiquitous telehealth, essentially allowing telehealth to occur over any desktop, any laptop, any mobile device, so that care could occur from anyone, anywhere, in real time. In an ideal world, this would be more than a one-to-one. It would be a one-to-many, where providers would come and participate in care for the patient around whatever was convenient for them, including a desktop, an iPhone, or even a routine pager with a callback. Multiple providers all sharing that virtual space around a patient. What we've done is combined two technology companies. Cisco WebEx provides video in the cloud. EmergeMD provides workflow, provider management, and transparency, effectively allowing a healthcare vertical on top of the Cisco horizontal tools. So in this case, you can see a deployed solution referred to as Consult Accelerator. If one wants to reach out to a physician, they simply click on their name and activate a text, a phone call, or a video to begin a conversation. Once the specialist comes on board, a WebEx session can be loaded so that there can be a desktop share between two providers in real time. So imaging can be displayed. If one wants to mark the images, both see the same images and the same marks at the same time to add for care. It doesn't simply have to be imaging. It could be an EKG or an EMR, and this could be again displayed over a laptop, desktop, or mobile device. This allows the continuum of care to occur, where information can be passed from an emergency room physician to a resident, to an attending, to a cardiologist, all in time. You don't necessarily have to click on their name, you could click on their role, but again, information is shared in the cloud using only a browser. On the back end, you can begin to see how the transactions have occurred during these events, so that you know who's talking to whom and for how long, basically allowing you to get some idea of the return on investment. Now, anytime providers are asked to do things that typically have been done by others, they often object. So what you don't really want is you don't want information being exchanged between two providers, but since you can do a one-to-many, instead the information can be held by the transfer center or paging operator, who then brings both care providers together in a virtual space for a real-time consultation. There are multiple business models where this could provide advantages, both in terms of telehealth in a traditional sense, as well as internal hospital efficiencies. So the most obvious ones are the fee-for-service model, the telestroke care or second opinion. There's going to be the rise of bundled payments and disease management. Keeping the patient with CHF out of the hospital today is a phone call. Tomorrow this should probably be a video conference between their nurse or their provider and them over time. Often overlooked are hospital efficiencies. These include conversations that might include nurse to doctor to doctor during the admitting process, the inpatient stay, as well as discharge. All of these involve time delays where information is not transferred for ready decision making. If we break this out into a traditional model, if one were to look at an urgent care or rural health provider, they're often in need of specialty consultation. But the specialist is going to ask, how much am I going to get paid for this 24/7 coverage? There are other models as well where the number of clinical transactions that convert to tertiary services are downstream revenue, but these are not often identified. The same is true if a hospital were to back up an urgent care or rural provider. The hospital wants to know, how many patients are you going to send me? What type of patients are they? And the rural provider and the ED, probably the outside ED, want to know, if I send you a patient, how long are they going to have to wait in your emergency room? Ultimately, what we really want to understand is, have we provided that patient a better outcome? Have we had something that's sustainable with a return on investment for all parties involved? In considering these, it can get quite complex very quickly. So take the case of a telestroke program. You want to begin to understand the number of cases transferred. What is the return on investment? This partly involves the net revenue, the payer mix, but also has variable and fixed costs for the hospital, as well as the spoke institutions. Physician reimbursement must also be considered. All of these factors must be taken into account when deciding whether or not telehealth transactions are sustainable. So what I've tried to take you through is the ability to put the right patient and the right care together at the right time. Today, we're working on old models, ones relying on pagers. Leveraging our experience with telehealth, care in the cloud is possible over any device, any network. Inherent in this is the necessity for workflow and outcomes if we are to have sustainable models. Thank you very much.